The subject that we're going to consider today is around rural perinatal health. And the format is we've got several speakers who will do around a 15-minute presentation. Then if you have any questions, if you could pop those into the chat, we'll ask each speaker if they're happy to take questions just at the end of the presentation. So we're going to kick off with Donna Cowan, who's a specialist midwife for perinatal mental health with NHS Highland. And you're going to talk to us about your new team and service that's recently started. So I'll hand over to you if you're able to share your slides.
Will do.
Thank you.
Thank you, Sarah Ann, and good afternoon, everyone. Let's see. Is that up in full, Sarah Ann?
Yes, that looks perfect.
Oh, thank you. Oops, I will just go back a bit. Back to the start would be helpful. Good afternoon, and thank you very much for this opportunity to speak this afternoon with you on remote and rural practice and accessing a specialist perinatal infant mental health service. My name is Donna Cowan. I'm the specialist midwife with the perinatal infant mental health team in NHS Highland. And for anyone who doesn't know, that just means everywhere in Highland, with the exception of Argyll and Bute, who have their own perinatal infant mental health service. With more than 1 in 5 women experiencing a mental health problem in the perinatal period, the Scottish Government in 2018 invested £50 million into perinatal and infant mental health services in Scotland. And in collaboration with individuals and families with lived experience, they produced the Women and Families Maternal Mental Health Pledge, identifying a number of expectations for a perinatal infant mental health service, including access to good mental health support, access to specialist services such as ours, no matter where you live in Scotland, and for professionals to have the right knowledge and skills to support them. So our service development in the North Highland area began at the end of 2021 with recruitment into posts. So as well as the specialist midwife role, the team consists of Roddy Monroe, our perinatal mental health nurse and the only male perinatal mental health nurse in Scotland, Susan Ross, our advanced nurse, clinical psychologist Dr. Mel Lees, parent-infant therapist Sarah Hughes, and we also have an advanced clinical pharmacist, Rebecca McClelland, who provides 1 session per week. This February, we've been joined by team admin Kate McManus and clinical psychologist Doug Hutchison as clinical lead. We still have some psychiatry sessions outstanding, but we hope to have those filled soon. So coming into post, the initial team members were flooded with inquiries for perinatal mental health advice and signposting. And that request for advice and signposting was echoed in a staff survey in February 2022. So on the back of the staff survey and the amount of kind of inquiries that we were getting, we realised that as service development for our service was continuing, we needed to do something about making ourselves more accessible and having time set aside for staff to contact us. So on 26th of April 2022, we launched our Pamper sessions. These are perinatal advice meetings and professional reflection. But the word pamper also gives that emphasis on the importance of self-care. This is allowing anyone within the health and social care partnership and the third sector from across Highland the opportunity to access our specialist perinatal service. The consultation model allows practitioners to discuss any mental health issue within the perinatal period, ranging from mild to moderate to severe or complex perinatal cases. And this is available to staff from preconception until an infant's 3rd birthday, which is in line with our pathways, but given that we have 3 strands to our service with perinatal mental health, infant mental health, and maternity and neonatal psychological interventions, the Pamper sessions allow us to span those 3 strands, which have very different referral criterias and age and kind of. That's me. I'm waffling now. Apologies. The perinatal mental health and MMPI service is from birth, from from conception to 1 year postnatally, and the infant service is from birth to 3 years postnatally. But as I even sounded there, it's all can be all very confusing. The Pamper sessions stops all that, and we just open that up to staff to come and ask us anything in relation to that time period, and hopefully prevents confusion. Sorry about that, I'm getting myself muddled up. So the Pamper sessions are held on Tuesday and Thursday mornings over MS Teams. There are 4 bookable sessions available each of these mornings. They last for 30 minutes. Consecutive slots can be booked, so staff can book up to an hour if they wish to discuss anything more complex, or if attending for their own professional reflection, which we've had a lot of success with, and has been fed back that that's been really helpful. So booking a Pamper session is really easy. It's through an MS app. Practitioners choose their own date and time to come. They're sent a link to join the meeting, and this can be added to their calendar. And we are the first team in Highland to pilot the use of this app. Practitioners complete a very simple form with details of the situation they wish to discuss, and this is returned to us in advance of the meeting. A minimum of 2 members of the perinatal infant mental health team attend a Pamper session and provide advice, signposting, support with any referrals that are required. And after the Pamper session, a practitioner receives a written summary of the meeting with any recommendations, advice, and signposting links attached to it. We carried out an audit of our Pamper sessions in December 2022, and this has assured us that staff are using our service and valuing it. In total, 76 sessions were booked during that time period, though this is not a reflection on the number of practitioners attending, only the number of families they wish to discuss. There have also been many students in attendance with mentors. Some practitioners have come together as a team, and other disciplines have also attended together, such as health visitors and midwives attending, or health visitors and GPs. We've had a fantastic feedback from staff who've used Pamper sessions, and have included some of their comments in the little stars on this slide. But from that, we've also identified themes from the feedback received. Staff reported the sessions improved their knowledge, skills, and confidence, and this could be shared with colleagues. The information gained could be applicable to other women and families in their care, and those in remote and rural areas felt included and less isolated, and they felt that this was a very accessible specialist service. This is just a whistle-stop tour of our, very brief mention of the specialist perinatal mental health service in Highland. I could talk for a good couple of hours on it, and I was conscious that what I did have to say might be more than the 15 minutes allocated. But we're very proud of our Pamper sessions, and we're very proud of the service development that we've carried out so far, and particularly in that it is fulfilling much of the maternal health pledge and the requirements of the Scottish Government. So thank you very much for listening. I am more than happy to speak to anyone beyond this session and answer any questions that you may have on a broader basis in relation to the perinatal infant mental health service in Highland. But if anyone has any questions that they wish to ask about Pamper sessions, I'd be more than happy to answer them.
That's great. Thank you very much, Donna. It's really good to hear about the work that's going on within NHS Highland. I don't know if we have any questions from the audience just now. I don't see any. If you've got anything you would like to ask, just pop it in the chat. And obviously Donna said she's happy to answer any questions out with the session as well. I think really interesting, Donna, to see that you're doing this. I think, did you say it was by MS Teams? So it's an online format. Was that a conscious decision in terms of thinking about accessibility, or maybe you could say a bit more about why you felt that was the right way to go about the format?
Thanks, Sarah Ann. And honestly, I did practice that. In fact, I took bits out because I thought I was going to run over, but I apologise because probably the speed it was delivered at has been sped up so much. Apologies. But yes, when we came into post, we're actually scattered all around Highland, the team themselves. So and particularly that was something when we came into the team, was that staff in Highland had hoped that services wouldn't be simply centralised in Inverness. We were keen that there was representation of the remote and rural areas and that there was access. So other teams across Highland have a kind of professionals advice line where they would phone in. So that was complicated in the fact that there wasn't one particular base for us, and as I said in my presentation, we only actually got admin in February of this year. So it was sort of impossible really to staff that, but also we wanted to kind of give when we were getting these informal inquiries and we were discussing them together as a team, it was clear that we all had a lot to give and a lot of advice and signposting. So it wasn't one particular thing. So we decided that we would trial the Pamper sessions and we would have this multidisciplinary team approach from the from our perspective. And what we're sort of finding is that it really is preventing any pinballing around services or that revolving door. So that, with other teams, when we've spoken to other perinatal mental health teams and infant wellbeing services and maternity and neonatal psychological services across Scotland, they actually are sort of standalone services. We are actually the only integrated team as well in Highland. So that was another sort of positive, that we do discuss these at a consultation level to start with. All the referrals that we've received to date, and our referral form went live. We've got a digital form that went live at the end of November, and Sky Gateway referral form went live just yesterday. So we're aware that the referrals that have been received are completely appropriate and have all been accepted by the team to date. So that's it's changed the narrative around the way that we speak to the women and families as well. It's, instead of that, I'll refer you to the service, it's I will speak to them first, we'll see what we can do, and it allows for a stepped approach, and all sort of disciplines are involved in that, and it allows that liaison with maternity services. It certainly seems to have improved liaison with maternity and obstetric teams, and mental health services as well. I hope that
That's great.
answers that question.
Yeah, definitely. Thanks, Dawn. It's really interesting. We did have one question from a member of the audience, I guess, just quickly before we move on, if that's okay. And that's, do you address substance abuse issues or substance misuse issues under the mental health umbrella?
Absolutely. So if women have an existing mental health issue, or something develops during the perinatal period and there's substance use issues, that's absolutely something that would sit within our services. We did, when we come into post, there was actually a substance use midwife, specialist midwife in Highland on secondment. She was doing from September 2021 to September 22. She was in post. At that time, it wasn't a substantive post. She returned, secondment ended. But I'm aware that there is discussion around HADAP, Highland Alcohol and Drug Partnership, funding this going forward. So that's really exciting piece of news as well. And that's really just sort of being discussed at the moment, how to take that forward.
That's great. Thank you very much, Donna, for sharing
Thank
that.
you for those questions.
So I think we'll move on to our second speaker, is Dr. Lucy Thompson. She's a Senior Research Fellow with the Centre for Rural Health at University of Aberdeen. and she is going to give us some reflections on evaluating the perinatal and infant mental health workstream in Highland. So thanks, Lucy.
Thanks, Sarah-Ann. Let me just get my slides shared and hopefully that'll work okay. And let's just get it into, is that showing okay in slideshow mode? Might take a second.
It's still thinking about it. It's not in slideshow yet, but
it took a minute when we did our trial run, didn't it? So it's certainly looking like it's within the screen share for me. Not in slideshow.
We can still see the whole screen, but there you go. It's changed.
It's changed now.
It's on slideshow, yeah. So nice.
Isn't it funny how long it can take sometimes? Okay, thanks, Sarah-Ann. And following on from Donna's talk, I was asked about a year ago to come up with an evaluation plan for this work stream in Highland, across the whole of Highland. So I'm going to talk a little bit about what we've done so far and what our plans are. So background, Donna's already given a bit of a background to the piece of work, the funding that actually came from the Scottish Government for this work to start happening across all the health boards. So there was a needs assessment which led to the setting up of the Perinatal and Infant Mental Health Programme Board. And this is just the front of one of their annual delivery plans. They're due to disband next month actually, so this has been an ongoing piece of work which has kind of been handed over to the health boards now. Donna also mentioned the pledge, and I bring it up here. This is obviously one of the pieces of work that came out of the board, but I bring it up here because this is a representation of what we're aspiring to with this, what the intended outcomes are. So you'll be able to see, and you may not be able to see it on your screen here, but if you look this up online, you'll be able to see on the graphic that the figures are holding up signs that say things like, I'm given advice and care if I have a pre-existing mental health problem. I'm able to talk about my mental health without fear of being judged. My baby will have parents who have good mental health support. So these are the ultimate outcomes that this piece of work is looking to attain. I also just wanted to mention that Donna also completed a mapping exercise specific to Highland, North Highland, which also serves as useful background to what was already there before this funding came into place. This is a really summarised version of the different care pathways that, again, this information comes from the national group, and the local health boards have to develop their own versions of pathways that fit underneath these broad headings. Now, when I look at this, I'm a research psychologist by background, but I also have a public health special interest. The thing that's really missing for me is that universal service. That's not really indicated in these pathways, but that's not to say that there isn't a view to having a kind of a universal aspect to the service in the health boards, and that applies to Highland as well. So you'll see here the kind of broadest level of service at number 1 is preconception advice for women with pre-existing severe or complex mental health problems. And I think most of us feel there needs to be more of a prevention aspect to this work as much as an intervention aspect. So I probably don't need to tell anybody in this audience about the geography of Highland, but it's relevant just as a backdrop. So this piece of work covers the whole of this area. I can't remember where I actually got this graphic from in the end. I put it on a slide last year, but the purple part is Argyll and Bute. And I have been working with Argyll and Bute around this evaluation as well. And I know Donna's team is working with the Argyll and Bute team as well. But because of the geography, they are naturally a separate service for a number of reasons. Part of it is because they're so much closer to Glasgow and to Paisley. They get a lot of their specialist services from that part of the country. So it's just a different sort of a picture, but they're still dealing with significant rurality, and in some ways, some more complex rurality than we have in North Highland, I think. I used to work in Argyll and Clyde way back when it was still Argyll and Clyde Health Board. And yeah, it takes a long time to get from A to B. So it's quite difficult working on some of these services, I think. So that's the geography that we're dealing with. And as Donna mentioned in her talk, there's 3 main pillars of activity. There's the perinatal mental health aspect, which is probably the most developed aspect, I think, in most of the health boards at the moment. There's the infant mental health aspect, and then there's the MNPI aspect as well. And how it's worked now is the team is working as a single team, certainly in North Highland, but I think it's taken a wee while to get us to that stage. I'll say a little bit more about that in terms of my experience around evaluation. So this is a graphic that I was given when I was first asked to take part in this, and it's just a slightly different way of expressing the different levels of service, as I showed you in a previous slide on the care pathways. This is the specific steer that I've been given from Highland around the sorts of things that it was intended would take place. Apart from this, there's not been a huge amount of information for me. Usually when I start an evaluation, the first thing I'll do is I'll sit down with the relevant stakeholders and say, well, what are we trying to achieve? What's the problem? What are we aiming for? And what are you planning to do to get there? And how can I help you measure that? There's been a bit of a lack of clarity about that. At least there was a year ago when I first came on board, around what specifically do you want to happen and what specifically are you doing to get there? So that's influenced how I've approached the evaluation. So what I did last year, I was advised that the best thing to do in the first phase of this evaluation was just speak to a bunch of people. Although I've been based in Highland for a number of years now, I haven't done an awful lot of work with the health board yet. So some of it is just about getting to know people. Who are the right people to speak to, and what has their experience been so far? So it's a really fun part, actually, is just to have lots of informal chats with people. I don't even have to do anything much with the data, no formal analysis. So what I was able to establish from those interviews is there's very much been a phased introduction to the service, naturally, because as Donna said, the service kind of started as the posts started being occupied, and that's kind of happened over a fairly phased period. There's definitely been a sense of just getting on with it. You know, most of the people that have been put into these posts already worked in Highland in some capacity and had some knowledge of the sort of work that was going to be needed. So there's been a sense of, right, okay, what do we think needs done? And a lot of perhaps carving out roles for oneself rather than necessarily working to a very specific directive. There was a lack of central leadership. So there was strategic leadership, there was a programme board locally to NHS Highland, but actually there was no single manager that was kind of had the responsibility for the whole service. That's since been resolved, but this time last year it was definitely something I was hearing from people was a bit of an issue. Lack of accommodation, it's an age-old problem in the NHS, but there was not just a lack of office accommodation, but also a lack of clinical space, private clinical space to see some of the families needed. That remains an ongoing problem. No admin support, which, as Donna said, since this month, there is now admin support. So this is how long some of these things have taken to put in place. One of the things I got from my informal interviews was, as well as this, oh, we just hit the ground running and getting on with it approach, from other professionals I was hearing, oh, well, that's not the right thing to do. We need to take our time and really plan before we start doing anything. And I'll say a wee bit more about that further on down the road once the formal evaluation findings come out. But I think what we're dealing with there is slight difference in work cultures and work practices, possibly connected to differences in professional background. That's what I'm starting to get a feel for. There's of course going to be fragmentation for something like this. As we've already talked about, NHS Highland is a vast area, and we've got the kind of two council administrations of Argyll and Bute and Highland Council. There's also the fact that there are different aspects to the service and different specialisms within there, and you know, did it really feel like there was a single service, or did it just feel like things were perhaps related but not as interconnected as we would like? And again, I think since I did these informal interviews last year, I think there's been improvements in that respect. Everybody was talking about how important maternal and family voices are to the development of this. The government certainly put that, and the programme board put that as central to the development of the implementation. How possible it's been to really include family voices is varied, I think, and I'll say a wee bit more about that in relation to my data collection. But I don't think anybody would deny that it's important to find out what the experience of families are, and especially mums, in going through services. I don't expect anybody to read this slide. I've put this up as an example. So back to me trying to plan an evaluation strategy. Again, normally what I would say is, what are you trying to achieve? How do we measure what you're doing to see whether you're getting there or not? This is from a national document. There's an evaluability statement prepared by Public Health Scotland in relation to this piece of work on a national scale. What you may be able to see there is there's short-term outcomes, medium-term outcomes, and long-term outcomes articulated. And then you see all the lines showing the relationships between them. this is obviously a useful exercise to do. It's the sort of thing I would probably do, but it gets to the point where it's very difficult to represent it visually and actually find it a quick access thing to deal with. But some of the short-term outcomes are the kind of implementation aspects that the Health Board has been working towards. And in the medium-term outcomes, for example, the one at the top says women and their partners with perinatal mental health problems are able to access appropriate support promptly at the level needed wherever they live. It's quite a big aim, but that's the sort of question I'm asking in my evaluation is, are the right people getting the right service at the right time? So after doing that set of informal interviews, I've gone on to come up with as best I can an evaluation strategy. Now, Public Health Scotland is doing its own evaluation on a national scale, which will include Highland. They've only recently commissioned that piece of work. I'm actually due to meet with the team again this week, I think, to get an update on that. But we've basically just got on and done something that will be useful to the Health Board now in the phase that we're in. So the objectives that we came up with, I'm just going to have to move this out the way a wee bit to characterise the implementation so far. So basically, what's happened, what have we managed to achieve, and what's outstanding still. Oh, sorry, click back on that. Obviously, to explore the barriers and facilitators there. So if things aren't happening, then what's been the reason for that? And if things are going well, what's helped? I think the main focus is really to describe the experience of families who have used the service in relation to, we try and relate that to the care pathways that have been developed. To understand the needs of families and whether they feel their needs are being met, and to understand the extent to which their voices have been able to inform the implementation, and then to make recommendations for ongoing monitoring and evaluation. It's early days for this work programme just now. I'm only commissioned to work on this until the end of next month, and I'd really like to see an ongoing piece of work, whether that involves me or not, but I do think it's important to keep going with this. So the approach to this is fairly straightforward. It's starting off by just gathering as much information as I can from the documentation that various stakeholders, mostly the teams have involved, have already gathered in relation to the implementation. So things like the care pathways, which have been under development for a wee while now, some of which are finalised. Bit of evidence collation, as Donna mentioned, they've been taking feedback. Pamper Session's been running for a good while now and getting good feedback. And so if there's any kind of evidence like that, I would like to include that, at least in a summary form, in the evaluation report. But the main thing for me is the interviews. So conducting interviews with the key stakeholders and service users to explore basically how people's experiences have been around the implementation of the programme. And I think it's quite important to have it as a specific aim that we have a review and consolidation process that then plans for the next steps as well, which links to that kind of ongoing monitoring and evaluation. Ideally, again, have families involved in actually discussing what's been found and how they would reflect on that, as well as the key stakeholders. So what have we done? I've interviewed 8 stakeholders so far. So this is since coming back in the new year. The piece of work, it's not a piece of research, it's a piece of service evaluation. So but that still means it's subject to certain approval. So we got Caldecott Guardian approval just before Christmas. So we got going in January. I've spoken to 8 stakeholders. I've got 4 more scheduled. You never know, I might get a couple more, but you know, my emails might be weighing down their inbox by now, so I might have reached my limit. I've actually only spoken to 1 service user so far. I've had 3 express interest, and 1 I've completed an interview with, but the other 2, you know, it can be difficult to, I don't want to say pin people down. That's not a very positive language, but that's, you know, actually securing dates. And, you know, things come up. People have got small babies and, you know, they may still be experiencing mental health issues. So it's not always very straightforward to get these seen through. However, we had a useful meeting. Donna's been running a Maternal Voices group, which is mostly third sector staff from across North Highland. And that was quite fruitful last week. I had a couple of the people from the meeting get in touch with me immediately to say, come along to our group, and we'll either get people scheduled for one-to-one interviews, or they might want to speak to me as a group or a pair or something like that. So I'm adapting the schedule or the protocol to allow for that to happen. And if people want to talk to me, but they're actually more comfortable talking with their friend by their side, then absolutely, we'll go for that. So I'm speaking to a group down here in Inverness, and I'm also going to be going to Caithness in a couple of weeks as well. So trying to be as inclusive as we can. Ideally, I think, given this is a small scale piece of work, I think developing some case studies. I've met with Donna recently, and hopefully we'll identify a practitioner. We've got some practitioners that come to PAMPR sessions quite frequently, and hopefully we'll have a couple of keen practitioners who'll be happy to suggest to one of their patients that they might want to take part in the evaluation, and we can actually kind of put pieces together around the care pathway and demonstrate what it really looks like from both practitioners and service users' perspective. And again, as I've already said, some sort of discussion of findings and recommendations and the opportunity to feedback, I think, would be ideal, but that's not really within my hands. That's up to the health board about whether that's what they would like to do or not. And that's it from me. There's my email address there if anybody wants to get in touch with me separately, but otherwise I'm happy to take any questions.
That's great. Thanks very much, Lucy. Really interesting to hear about the work that you're undertaking. I was going to ask you potentially about some of those medium and long-term outcomes and whether you might get there, but I think you've probably answered that question, that this piece of work's maybe not going to be able to include that. But I guess I'm wondering, did you have any reflections on what ideally you would like to see happen in the future? Like what kind of timescales might be associated with seeing some of those long-term benefits, and maybe what would some of the methods be to try and trace those through? Did you have any thoughts around that?
I think we're seeing some of them already, and I think, Donna, I don't know if you would agree, but I think for some families, they're absolutely getting what they need when they need it, and it's already, so they can tick the box in terms of my mental health has been well looked after. I think what we'll find is it's probably the families that are less visible to us are the ones where, and it's how as an evaluation team, we were actually able to access those and actually get a real sense of that. I am talking with colleagues about doing a larger kind of national piece of work that makes use of routine data to try and get to the bottom of some of this. I think especially with infant mental health service, the infant mental health service is less well developed at the moment. For a range of reasons. People didn't come into post until later and things like that. But I think there's a need to actually be asking who is actually accessing these services, and how representative do we think they are of the people that might actually need to access those services. I think you can only really reliably measure something like that over a much longer period. People I've been speaking to would say it'd be nice if we could be revisiting some of this in 2 years' time, and that's probably what I would agree with as well. So I think a couple of years' time is probably reasonable to have a firm service in place where we can feel a bit more strongly that we are ticking the boxes. Having said that, midwifery and health visiting being two of the main professions that are on the ground are understaffed and under-resourced, and so those things are always going to be an issue in terms of actually trying to make the service happen. I don't know if you would agree, Donna.
No, completely agree with that, and I think for what we're finding with the remote and rural areas is the accessing services that for example, we have a service in Grampian, a third sector organisation in Grampian who support women with perinatal infant mental health issues called Latinum. But for a number of years, they've actually been supporting women across Highland, although this wasn't known to staff. Women were finding Latinum themselves, and actually that is a plan for the future for them to be more visible in Highland, but certainly we've been signposting and I've been advising midwives and health visitors about their service. There's also Dad's Rock down in Edinburgh. They've just received money from the NSPCC for a piece of work to expand their peer support online. So some families in the remote and rural areas love that kind of access to online services and the anonymity of receiving peer support. So yeah, I think that families we're learning more as we're going along, and I think that 2-year review would be fantastic.
Mm-hmm.
That's great. Yeah, it sounds like it would be a really important piece of work for Highland and beyond in terms of rural communities as well. So I think there's been a couple of questions in the chat, which I think you've answered, Donna. So thank you for that as we're going along. So I think we'll move on to our third speaker, if that's okay. So Dr. Jonathan Scher. who's from the Queen's Nursing Institute for Scotland. Jonathan's a Senior Fellow and Programme Lead, and is going to speak to us about the Healthier Pregnancies, Better Lives. So I'll hand over to you, Jonathan. Thank you.
Thank you. I'm honored to have been asked, and I'm especially honored that you all would be here for a presentation, because at least for me, this is not how I always imagined spending a Valentine's Day. But happy Valentine's Day, and I'm glad you're here. I'm also glad to be the third speaker because I've learned a good bit from our previous two speakers, things I had not been aware of that are interesting and exciting and absolutely worthwhile. So this has been a good learning opportunity for me. As Sarah said, I work at the Queen's Nursing Institute Scotland, which is a charity that has been around for 134 years now. And it was created to help the wording then was to help the sick poor in their homes and communities. And it's still has a strong focus on deprivation, on overcoming inequalities, and on working with community nurses in all of their various roles, and midwives in every corner of Scotland, absolutely including a number of Queen's nurses in the Highlands. I used to give a talk, and it started by asking a question. And the question was, what's the difference between Las Vegas and early childhood? Probably not a question that you've had to answer very many times in your lives. And because this is a brief presentation, I won't go through all the different answers I've heard over the years. But the one that is my answer to that question is that, at least reputedly, what happens in Vegas stays in Vegas. But what happens in early childhood never just stays in early childhood. What happens, for better or worse, stays with us for the rest of our lives, not only for us, but for our children. So what happens early genuinely matters, and that's why programs like the ones you've heard described are so important, because it is a shame and a waste to wait too long. But I've come to understand something else in recent years, which is that early, I used to think meant at birth, or early meant maybe during pregnancy. But I've come to a very different opinion over the years, which is that those are obviously important periods. Obviously, you need to do whatever you can do to make them as good as possible. But what often gets left out is preconception, pre-pregnancy. And so the work of Healthier Pregnancies, Better Lives is fundamentally about preconception and interconception, health, education, and care. So before the first baby or before the next baby. But the keys to it are prevention of harm and promotion of good health and well-being. And the examples given today actually provide a very good context for that. I'm sure that you know there's been a long time concern about postpartum depression. And for a very long time, the assumption was that postpartum depression is the result of hormonal changes and chemical changes in the last trimester of pregnancy and in the childbirth process itself. And it's not that that never happens, but we know better now. And the research is very clear that the vast majority of people who experience postpartum depression issues had pregnancy depression issues, but often they were unidentified and untreated. And the vast majority of people who had pregnancy depression issues had pre-pregnancy, preconception depression issues, often untreated, often unidentified. And if you step back a couple of steps and ask yourself, so when really would be the best time to identify depression issues and symptoms? When would be the best time to begin to deal with them and resolve them as best we can? Not many people would say, oh, well, obviously the best time is after childbirth because it's such an easy peasy, carefree, unstressful time. And in fact, the best time would be preconception. So there are a whole number of things which are best done preconception. And that's more broad than the one thing I was pleased to hear Lucy mention, which is that there is sometimes preconception assistance available to people who have severe or complex mental health issues. But again, that's a relatively small part of a population, and it's much broader that there are people who would not be classified as having severe and complex mental health issues who do have mental health issues that are compromising their own health and well-being and create a risk for the health and well-being of the child to whom they will be entrusted. And so there are a number of things best dealt with preconception. And there are some things that can only be dealt with preconception. And the two easy examples are folic acid, because folic acid prevents neural tube defects. The research done here in the UK more than 30 years ago showed that enough folic acid early enough can prevent about 80% of neural tube defects. And neural tube defects are not just about spina bifida and hydrocephalus. In fact, there are many more unwelcome, unhappy endings than those. For example, neural tube defects are a major cause of miscarriages and of stillbirths and of neonatal deaths and of therapeutic terminations once a pregnancy screen has revealed that the fetus has a neural tube defect. So preventing it would be a good thing. And I've talked with lots of GPs and midwives and obstetricians who shake their head with sadness about the number and frequency of women who show up at first booking, which is, as you know, is normally 8 to 12 weeks, and say, I've heard folic acid is a good thing during pregnancy. Should I start now? And the reason it causes a reaction of sadness is that the neural tubes are completely formed or malformed by the end of the 4th week of pregnancy. That is, before the vast majority of women even know that they are pregnant. And we still live in a society in which roughly half of all pregnancies are unintentional, mistimed, accidental. But if you don't start taking an adequate amount regularly of folic acid for months prior to pregnancy, then and during the first trimester of pregnancy, then there's a serious risk of neural tube defects. And neural tubes, just for you who haven't studied this lately, are what become everybody's spine and brain and central nervous system. A reasonably important part of who everybody is and what everybody needs. The other example are medications, valproate being one which is now in the news, that cause birth defects, that are a risk of causing birth defects. They are known as teratogenic, that is, birth defect causing medications. But stopping them during pregnancy is a very bad idea. They need to be transitioned off of over a period of time, and then substituted all prior to pregnancy. But if there's no preconception health care and education, then that doesn't happen. So we created a program called Healthier Pregnancies, Better Lives. And it's grown from, in less than 2 years, it's grown from an idea to a program at the Queen's Nursing Institute Scotland to now Scotland's Coalition for Healthier Pregnancies, Better Lives. And I'm delighted to say that the Scottish Rural Health Partnership is one of the now 83 and counting partners in this coalition. And so I think that that there is enormous promise for what will be accomplished, because this is not a coalition where people lend their good names or sign a petition. This is explicitly a coalition of doers. Every one of those 83 partners has committed to doing something new each year in their own community, in their own networks, in their own spheres of influence that advances healthier pregnancies, better lives. And the combined and collective impact of all of those partners doing those things in their own ways, in their own places, I think will be just extraordinary. So that's the work that I do. I'm happy to tell you more. My email address is in the chat, along with our Twitter account and along with the part of the website where you can get lots more information about all of this. But I guess I want to end my part of the presentation by noting that you can tell from my voice that I'm not originally from Scotland. But I have been coming to Scotland since the late 70s on work. And for the first half of my career, that work was in rural communities on 3 continents, including a good deal of work in Scotland. In fact, I ran an international rural project, and the final international conference was held in Stornoway. So people from 18 nations came to that rural conference. So rural issues have always been and remain very close to my heart. And the issues here of preconception, health, education, and care, of preparing well and making decisions about whether to delay pregnancy, avoid pregnancy, or prepare for pregnancy are ones that are at least as important in rural communities as in any other. So I'm delighted that there is such a thing now as the Scottish Rural Health Partnership. It didn't exist. In fact, UHI was just the gleam in the eye of people at the Highlands and Islands Development Board when I first was coming here. So I'm very pleased with this work. I'm happy to answer any questions, but I encourage you to follow us on Twitter, to visit the website, and to contact me directly with any questions, concerns, or ideas that you have. The one other thing I would be remiss not to note is that another preconception issue has to do with fetal alcohol spectrum disorders, FASD. And again, the Scottish government itself has identified that there are at least 172,000 children, young people, and adults who have this lifelong, life-diminishing neurodevelopmental condition, many of whom are in rural communities. But of the 172,000 plus, less than 1% have ever been officially diagnosed or properly assisted and supported, let alone preventing FASD, which is preventable in most cases. And so I mention that because there are some resources even in Highlands. One of the Queen's nurses is Helen Gilpin, who works in Highland, and her particular part of the work is doing assessments of children and young people who have mental health issues or learning disabilities. And she'd been doing it for years, and FASD was never part of the equation, as was true everywhere else in Scotland. But now it is. And she's a wonderful resource who, if you've not had a chance to meet Helen, I would encourage you to meet. So that's the overview of what I'm up to and what I'm thinking about. And I would genuinely welcome questions now or contact afterwards.
That's great. Thank you, Jonathan, and thanks for your support for SRHP as well. And you're highlighting some of those really important issues for remote and rural communities. And yeah, I think you've put your website and your contact details in the chat, so
yes,
people can get in touch. I think there was just a couple of comments. Donna was highlighting some of the QNIS work as well in Easter Ross around the Catalyst for Change project, which
yes,
sounds really interesting too. And just some recognition from the audience members as well about the importance around awareness of parents' own adverse childhood experiences, which is important around any pregnancy. So yeah, thanks for highlighting those issues, Jonathan. So I think we've come to the end of the webinar for today. Just want to thank all our speakers again. I think we've highlighted a really important topic, and it's been fantastic to hear about the different approaches to your work as well. We've recorded the webinar, so it will be available for SRHP members as well afterwards. And thanks to everyone who's attended. We will be organising another webinar for April, so we'll be sending out the date and the topic for that shortly. And we'd love to hear from anyone who has any ideas around topics to highlight for future webinars as well. So thanks again to everyone for your participation today.
Thanks.
Thanks.